Hey folks, well, welcome to the Friendly Neighborhood Oncologist. I'd like to give a special shout out to everybody in the community who wants to immerse in the Oncoverse. And if you're not part of that community yet, please consider subscribing to the channel. It's always free. I'll never direct message you. Uh, Please consider smashing that like button or destroying it, as the millennials say. It's got to get the Friendly Neighborhood Oncologist a few likes and subscriptions. Why not? I'm a board certified medical oncologist in private practice, and I practice in the suburbs of a major metropolitan city here in the United States. It's not too far away from a top medical school and a top academic cancer center, both places where I did significant amounts of training. So on a daily basis, I just try to help patients. So I try to help patients kick cancer in the you know what. And of course, there's a lot of information and a lot of misinformation that's out there on the web. And so this channel is just trying to connect people to consensus guidelines for particular diagnoses. So again, I'm not your board certified physician. Nothing I say should be construed as a medical opinion or a diagnosis or a recommendation to stage and treat. But we're here simply talking about information and resources that are available. So without further delay, let's get underway and immerse in the Oncoverse. So today we're going to be talking about non-small cell lung cancer, and we've touched on early stage resectable lung cancer, that's non-small cell, and also touched on advanced non-small cell lung cancers. Well, this is the NCCN guidelines, and again, I'm not a medical representative or legal representative of the NCCN or the American Society of Clinical Oncology. This is just a standard of care consensus guideline that's free and available at nccn.org. And so we'll have certain patients who unfortunately have already been diagnosed with non-small cell lung cancer, like adenocarcinoma or squamous cell carcinoma, and they've been clinically staged and seen cardiothoracic surgery, and we've had discussions in tumor board with pathology and radiology. And unfortunately, they may have particular staging that shows certain nodes are positive, or other reasons that they're not necessarily candidates for surgery. And of course, these patients have already had pulmonary function tests, PET CTs, brain MRIs, and they've had a lymph node investigation. And you'll see that in these patients that for lymph node positive disease, that's N3, the current recommendation is chemotherapy and radiation. This has been a long-standing recommendation for these folks, and I won't belabor the type of platinum doublet, be it cisplatin-based or carboplatin-based, or the best taxane versus etoposide. Those are discussions for your medical oncologist. But what I was going to emphasize here is that until fairly recently, after chemotherapy and radiation, the standard of care used to be surveillance. So until fairly recently, no matter what clinical trial was done, we had no treatments after concurrent chemotherapy and radiation that showed an overall survival benefit. And that changed fairly recently. And of course, I'm referring to the Pacific trial published in the New England Journal of Medicine by Dr. Antonia and colleagues, which established this immunotherapy durvalumab after chemotherapy and radiation for patients who had not progressed for this particular stage of non-small cell lung cancer, and to be receiving this immune therapy as long as they were good candidates for treatment, didn't have any contraindications. And then we would follow with surveillance. And of course, after that treatment of durvalumab and on surveillance, these are recommendations for clinical follow-up of CT scans, lab work, et cetera. Of course, we're always working on prevention, so smoking cessation advice. And I'm just going to quickly click on the New England Journal of Medicine article. And again, I'm a subscriber to this. Again, I'm not speaking on behalf of the New England Journal of Medicine. I'm not their medical or legal representative, but this is just standard of care. So Dr. Antonia, who was the first author with the Pacific trial, this article was published in December of 2018 in the New England Journal of Medicine. And the primary endpoints were both progression-free survival and overall survival in patients who had stage 3 unresectable non-small cell lung cancer, who had received concurrent chemotherapy and radiation and who had not progressed. So they randomized more than 700 patients 2-to-1 to receive the immune therapy durvalumab versus placebo. And the 24-month overall survival rate was higher in the durvalumab group versus the placebo group. And in terms of the relative benefit, what the statisticians would call the hazard ratio for death was 0.68. So there was a 32% relative benefit in terms of overall survival. And of course, the trial goes into detail about the side effects of durvalumab immunotherapy, certain contraindications, which patients would be appropriate, not appropriate. But I think the important thing is that until this trial got published, we had no other treatments that were shown to have overall survival benefit for unresectable stage 3 non-small cell lung cancers after chemo XRT. And I think that's the main point. And on that note, thanks everybody who wanted to immerse in the Oncoverse. This is a friendly neighborhood oncologist, and I am out. And I'll talk to you all soon.